Thank you, Peter. So I'm going to focus on frontline management issues today. Here are my disclosures. So as Tom mentioned, there really isn't a standard of care or standard approach to mantle cell lymphoma still in 2014. It's not reliably curable with any of our current strategies. As a result, there are a variety of management options. Intensive type treatments, things that involve stem cell transplantation or the conventional hyper-CVAD regimen, appear to produce longer first remissions if used in younger patients. That comes at a cost. The cost is more toxicity, and so it's sort of a trade-off for the patients. Whether using an intensive strategy as the initial approach for younger patients improves the overall survival is really not proven in my mind. So if you want to choose a non-intensive strategy for younger patients, my personal opinion is that's okay. So mantle cell lymphoma, like a lot of diseases, is heterogeneous, and there are some patients who have a very aggressive clinical course and some patients who have a more indolent clinical course. When I'm talking today, I'm really gearing this toward the more typical mantle cell patient. This is an old paper now, but it discovered something called the Proliferation Index in mantle cell lymphoma based on gene expression profiling, and it identified about 25% of patients have a slower disease course, half the patients are right in the middle, and then about 25% of the patients have a really aggressive disease course. Unfortunately, we can't identify these patients totally reliably when they come through the door as a new diagnosis. There are some things we can do to give us estimates. So there's a clinical prognostic index in mantle cell lymphoma called the MIPI, and it identified 4 clinical factors: performance status, LDH, white blood cell count, and age. Fortunately, it's not a simple 1 point for each. It's a scale that requires logarithms. Fortunately, there's an online tool, and so it is possible to calculate this with a handheld device or a computer. Note that having a high-risk MIPI score is a relatively infrequent thing, only 21% of the patients in this study. The other thing I'll point out is that it is only occasionally helpful in the management of patients because, as you can see, age and performance status will put a patient into a high-risk category, and yet that's not a very conducive scenario for, intensifying your treatment. Whoops. Sorry. There are also some biologic features that you can use to estimate prognosis. So I think a really strong one is the proliferation rate. Tom mentioned this, and if the Ki67 stain is above 30%, and this has been shown in many, many trials, that's associated with a worse prognosis. A complex karyotype, if you do routine cytogenetics, is associated with a worse prognosis. That's the red curve. There are a few specific abnormalities, blastoid morphology, also associated with a inferior prognosis. As I mentioned, when you try to integrate these things into your management, occasionally this is helpful information, but not always. Where I find it most helpful is when I'm on the fence. And so if I have a patient and where I'm trying to decide if I'm going to pick an intensive strategy or a not intensive strategy, these prognostic markers may sway me in one direction or another. I'll make one quick point about watch and wait in mantle cell. I have to give props to my host here, Dr. Martin. So this was a paper published in the JCO, and a strategy that has been used at Cornell University fairly routinely is to take patients who are asymptomatic with low tumor burden and start out on a watch and wait strategy. And basically what their paper showed is it's okay to do that. There's no harm that's derived. So the smaller bars here are the patients that were able to be observed more than 3 months. Here are the outcomes for those patients from the time of diagnosis. Here are the outcomes for those patients from the time of their first treatment. That's the blue curve. So the paper clearly shows that there is no detriment to those patients by starting on a watch and wait strategy. So in my opinion, it's totally legitimate to do that in selected patients. Okay, so patient comes in the door, you're trying to figure out where to start. The first thing I try to figure out, is this a candidate for an intensive treatment or a less intensive treatment? Here are some examples of those: R-CHOP, R-BENDA, modified hyper-CVAD, VCR-CVAD, cladribine, all reasonable non-intensive options. Here are some reasonable intensive strategies. Conventional hyper-CVAD, not my favorite. I'll tell you why later. R-CHOP followed by stem cell transplant. R-CHOP alternating our DHAP stem cell transplant Nordic regimen. So I'll go through a couple of these in just a little more detail. So I think most people know that R-CHOP is just so-so regimen in mantle cell lymphoma. High response rates, 90% range, but the remissions tend to be brief, usually about 18 months. A couple of small randomized trials suggest that R-bendamustine is a little more active than R-CHOP. This was mantle cell patients pulled out of the STILL trial that was published in Lancet last year. So there were about 100 patients on the trial, median age 70, so truly an older group of mantle cell patients. And here's sort of the typical R-CHOP curve, pretty short remissions. R-benda performed a little bit better than R-CHOP did in that trial. The BRIGHT trial was published just this past year in Blood, very similar in design to the trial I just showed you. There were 67 patients with mantle cell in that. Half of those received R-benda and half received either R-CHOP or R-CVP. And the complete remission rate was better in the BRIGHT trial for benda rituximab compared to these. So again, more data suggesting that R-benda might be a somewhat better platform for your mantle cell patients who aren't candidate for intensive therapies. No matter which of these you choose, the remissions are still disappointingly short. These older patients, intensifying the treatment really isn't an option. And so to try to keep them in remission longer, trying to come up with a consolidation or a maintenance strategy is an attractive option. So published in the New England Journal of Medicine was a very large study from the European Mantle Cell Consortium in which patients received 2 different inductions. They showed that the FCR regimen was just too toxic for this older group of patients, and R-CHOP was a better induction in this trial. But if you focus on the maintenance part, patients are randomized to maintenance rituximab or interferon maintenance, and remission duration was improved with rituximab maintenance, and that difference was even more pronounced in the R-CHOP patients. So I think if you have a patient for whom a non-intensive strategy is what you think is the right approach for that patient, a reasonable standard of care right now would be something like R-bendamustine for 6 cycles, followed by maintenance rituximab for 2 years. I'm admitting that's an extrapolation of data because the R-maintenance was after R-CHOP, but I really don't love the R-CHOP backbone for mantle cell lymphoma. So I think we have enough experience with maintenance rituximab. I'm comfortable making this extrapolation at this time. And as Tom mentioned, this is the current intergroup trial looking at this backbone, BR times 6 followed by rituximab maintenance, and then looking at the contribution of Velcade or bortezomib to that induction, and then looking at the contribution of lenalidomide to rituximab maintenance. So this is an important high priority study that's going on right now. And we did get some data just this summer. This is not published, but this was presented at ASCO. That does show that in this trial where vincristine was pulled out of the R-CHOP regimen and replaced by bortezomib in the so-called VR-CAP regimen, basically it doubled the progression-free survival and time to next treatment compared to R-CHOP. So there is good evidence that adding bortezomib to conventional chemotherapy can potentiate it and make it more effective. So let's finish up talking for a couple of minutes about intensive strategies for patients who are candidates for intensive strategies. This is just kind of summary of some different studies that were published. Usually the response rates are very high, complete response rates, usually north of 50%. And the median event-free survival or progression-free survival in most of these studies that use intensive regimens usually comes in around 4 to 5 years with slight variations. But that's sort of where the bar is set now for picking an intensive strategy in a younger mantle cell patient population. This particular trial was a large randomized trial that is not yet published, but I believe will be published soon. And this trial was for patients under the age of 65. Everyone gets an auto transplant once they're in remission, and it asked an induction question, 6 courses of R-CHOP, versus 3 of R-CHOP and 3 of R-DHAP. Here's the schema right there. And just kind of getting to the bottom line, this trial provided evidence that adding the high-dose cytarabine improved the progression-free survival or time to treatment failure in this instance. No difference in the overall survival, but it made the remissions last longer. So based on this, in general, if people are nowadays picking an intensive strategy for a younger patient, they're generally electing to incorporate high-dose cytarabine into the regimen. My own choice for younger patients who can take an intensive therapy is the Nordic regimen. I like this one the best. The maxi-chop can be given as an outpatient. It just uses the cytarabine. There's no methotrexate, which I don't think adds much other than hassle and toxicity in mantle cell lymphoma. So I find it a pretty convenient regimen and tolerable for younger patients, and the long-term follow-up is outstanding, with the majority of patients still in remission at 5, 6, 7 years with this strategy. So summarizing regarding intensive strategies for younger mantle cell patients, the European trial I mentioned suggests that the way you get to this transplant might matter. Cytarabine could be a difference maker. And so generally it's worthwhile trying to incorporate that. I think there are several reasonable intensive strategies. Conventional hyper-CVAD is very active, of course. I'd remind you that was developed for ALL, very heavy in steroids, very heavy in vincristine, which I don't think are the best mantle cell drugs, so that's not my favorite. I like the Nordic approach, but I think the R-CHOP alternating R-DHAP is equally reasonable. I'll just finish up by mentioning, Tom hinted at this. There is this question, especially now with the new agents coming in, about whether the transplant is really necessary in the younger patients. This just shows the 5-year overall survival, and these are 3 different intensive strategies here. And here are 2 different studies that chose non-intensive strategies. This was the ECOG study that Tom mentioned in the Cornell series, and you can see there is no difference. Now, these are not randomized comparisons. These things don't exist. But there is a suggestion that that would be a question worth asking and at some point in mantle cell. So to summarize for upfront treatments, lots of reasonable options. NCCN guidelines list several options. If you have a younger patient, most of us think intensive. If they don't want to do that or you don't want to do that, I think that's okay. You just have to explain the trade-off. More intensive, generally longer first remission, but more upfront toxicity. For non-intensive, I like the BR backbone with our maintenance, and we have a big intergroup trial trying to add to that. This is being done in the cooperative groups right now. And Tom talked about some of the exciting new agents that need to be worked into frontline therapies, and then I think Peter now will talk about management of relapsed mantle cell. And that is it for me. Thank you.